My name is Erika Henry. I work with the Washington State Department of Health. My roots are right here with this healthcare coalition. The Region 9 Healthcare Coalition is where I began my career in emergency preparedness and response. My focus is primarily in the healthcare community across Washington State. But I'm a Spokane girl and still live in Spokane, though I work for the state. And I want to thank Adam for orienting all of us to, the fact that although we live in a relatively safe part of the country, we do still have many inherent and imposed hazards. So thank you for that orientation on that this morning. So I also want to apologize to you. There is a curse upon me related to this room. When I ran Healthcare Coalition meetings out of this room for 2 or 3 years, we had technical problems every single time. And since I've left, I've heard that the coalition meetings are completely seamless, flawless, no problems. And here I am back today. And we've had a little glitches, so that I completely take that on. Sorry about that. It just comes with the Erika territory. So I'm going to start us off this morning working towards an exercise. We want to really get everyone in the room thinking about what we're here today to discuss, crisis standards of care, and particularly the piece that I'm talking about is the allocation of scarce medical resources. I have some slides that we're going to work through, and then I'm going to introduce Dr. John Hick, who will come up and lead the rest of the presentation. So. Oh, I have this disclosure. I'm not used to doing disclosures. So I'm Erika Henry. I do not have a financial interest, arrangement, or affiliation with one or more organizations that could be perceived as a real or apparent conflict of interest in the context of the subject of this presentation. I'm sorry, that was so clunky. Also, I think when I turn my head, I lose audio, so I'm kind of just going to do this. All right, let me work through our slides here. So community values and the allocation of scarce medical resources. I want to give credit right up front. The state of Maryland did a lot of groundbreaking work around this particular topic. I've seen them present nationally at 2 or 3 different conferences. They were very gracious in sharing their resources with me for the purposes of sharing them throughout Washington State. So I want to give credit where credit is due. This is, again, just some more acknowledgments. This orange portion of the slide is directly from Maryland, so I just cut it out and put it in our slide so that we could make sure that we're giving appropriate credit. All right, so our overarching goals are to understand our community's values across Washington State, and to, of course, consider the best clinical opinions of Washington State healthcare providers, which is why we're so glad so many of you are here today. And similar events have been and will be held in different parts of Washington State. So what we want to do as we proceed down this path is to gather input from citizens. We want to reflect the values of the whole community makeup, all different aspects of our society, in regards to what they think we as clinical providers, you as clinical providers, should do about the allocation of scarce medical resources. Of course, we want and need provider input. And then we hope to, at some point, get to a final report detailing the results of these various engagement pieces and have some kind of path forward that we can work towards together. So today, we're not doing an official community engagement piece. We're really just here to start this process of thinking about and talking about this topic. We're not recording responses here. This isn't part of any formal process towards this end. So what we're looking at is, in a catastrophic event where we may not have enough life-saving resources for everybody who needs them, how do we decide who's going to get the resources? Essentially, how do we decide who may live and who may die as a result of our decisions? What ethical principles should we use to guide those decisions? What does the public think about how we're making these decisions? And how do we even begin to understand that or to figure that out? And most importantly, what do you think? So that's what we hope to get at during this little exercise now. So we are using a system called Poll Everywhere. This is available on your cell phone via text. I believe you received a cheat sheet in your packet, but don't bother digging through for it. If you have it in front of you, please look at it. If you don't, this is very simple. Just open your text application on your phone. The number you're sending to is 22333. And remote participants, feel free to also have a part in this. You can text from wherever you are. So anyone on GoToWebinar, open your text application. You're sending to the number 22333. And your first text is my name, Erika Henry, 966. It was assigned from Poll Everywhere. So Erika Henry, 966, and then hit send. That should enroll you in this Poll Everywhere portion of the exercise. Okay, we're gonna do a test drive. On the next, don't answer yet. The important thing about Poll Everywhere is you can't send your responses until we're on the answer slide, which looks very different from this. So I'm going to ask you, when I advance to the next slide, enter A. Just send a text that's the letter A to that thread that you have open, and we'll see how many people are actually able to respond. Or send B, if you can't respond, but that doesn't make sense. Okay, so we have 100% of respondents are able to respond to the poll, which is wonderful. What I don't see up here is how many that represents. Like, that could be one person. So, do you have the numbers over there? Does it show you how many respondents? Somebody do me a favor and type B. This is why we have 2 responses, so we can test drive. Excellent. Oh, thank you so much. Okay, so we know that we're working. All right, so what I'm going to do now is turn this over to Dr. John Hick. I'm going to introduce him now. Dr. Hick is wonderful because he said this morning, I was talking about his introduction, and he said, the less introduction, the better. Just say, you know, here's this guy from Minnesota. And I said I'm not going to do that. So especially as I read through his bio, I really want you, especially being members of the clinical community, I think pieces of Dr. Hick's bio will really resonate with you in regards to this topic. So if you'll forgive me, Dr. Hick, I am going to read just a little. I'm going to make it short. Okay, this guy is super awesome. So that's the short introduction. But he's a faculty emergency medicine physician at Hennepin County Medical Center, and an associate professor of emergency medicine at the University of Minnesota. He also serves as the associate medical director for the Hennepin County EMS and medical director for emergency preparedness at his medical center. He's a medical advisor to the Minneapolis-St. Paul Metropolitan Medical Response Team. He also serves as the Minnesota Department of Health medical director and the medical director for hospital bioterrorism preparedness. So he's very active in emergency preparedness and response work, and very active in his community. I also want to note, Dr. Hick has published many of the initial articles and resources related to resource triage, and he created the conventional, contingency, and crisis standards of care constructs that have been adopted by the Institute of Medicine and our federal government, HHS ASPR. He's been a member of various national committees related to crisis standards of care, and is also involved with a project by the American College of Chest Physicians. So we have a very esteemed colleague here with us today to lead us through the rest of this exercise and then his own presentation on crisis standards of care. So again, forgive the clunkiness. We do have to transfer 2 microphones over to Dr. Hick. So please pardon any buzzy noise. There you go.
Thank you.
Yes.
See, that's the problem with those introductions, is now you guys expect big things, you know. So can I just get a really quick show of hands? How many here are public health? Okay, and how many are hospital but administrative or infection control, stuff like that? Okay, and how many are clinical staff? Awesome. How many EMS folks? No EMS. Okay, somebody call 911 and, okay, all right, we've got one. Okay, good deal. All right, well, at least there's one, you know, and so if we need an AED or anything, you know, we'll who to call. So, well, good. Well, that's a really nice mix, and I want to thank you guys for taking time out of your busy schedule to be here today. what we're going to do first is just kind of go through a few questions here. And I think people, one of the things I want to get off the ground first of all conceptually is that crisis standards of care, we often think about in these really black and white life and death terms. I'm taking your ventilator away, and that's a very small portion of what you should be thinking about crisis standards of care being. We really need to think about crisis standards of care as being what happens when your usual surge capacity plans don't meet the needs anymore. So you're having to go from making those decisions about, if for my clinical providers out there, who works in ER? Okay, so when we triage people, what's our goal? What are we trying to do?
Highest priority first.
Yep, highest priority first, exactly. And so it's not that the other people are never going to get into the ER. Some nights it seems that way, but it's prioritizing the access by time. It's not saying, well, you're not going to be able to come in. Unfortunately, sometimes we get to the point though where we do have to make triage decisions about, it's just not appropriate for you to be in an ER, which I'd like to be able to do every day, but I can't. But you can't stay. Sorry, we're going to have to send you to a clinic. You're going to have to go home. But basically, you're never going to get into the emergency department with the current situation, with the pandemic going on or whatever else. So those are, or we'll have to adjust and do things a little differently with our admission decisions and say, yes, you've had this chest pain, but instead of admitting you, we're just going to do a couple troponins in the ER and we're going to send you home. Not our usual procedure, but we have to accept a little bit of risk because of the situation the hospital's in. So crisis care is really a spectrum, and it really has to do with when just sort of usual surge capacity runs out, then what do you do? But there's a lot of elements to it, from the prevention side of when we only get a certain amount of pandemic vaccine in, who gets it? And you guys probably had to do the same thing we did in the state of Minnesota, was figure out priority groups. Those priority groups in Minnesota were different than the priority groups in Wisconsin. So healthcare providers that I had that worked in our healthcare system in some small hospitals in Wisconsin were getting vaccine because they were a priority group in Wisconsin but not in Minnesota. That didn't play so well. It's like, well, what do you mean I'm not a priority in Minnesota? It's like, well, we decided that the kids who were most likely to get sick would get the vaccine first. So you can talk to the kids and negotiate for some vaccine for yourself. So it wasn't a matter of bad decisions, but it was a matter of needing to have consistent communication and a consistent plan, which is a lot of what crisis standards of care is. It's not making ad hoc decisions in individual facilities or individual places that wind up, being difficult to communicate or difficult to justify. So we want to ask you guys a couple of questions and get some feedback, and that'll kind of help set the tone for the morning here. So during a public health emergency like a pandemic, are there certain people or groups of people who should be first in line for treatment when there's not enough treatment available to help everyone? So whether that's antivirals, all the way to like ventilators, and don't vote yet, but should we do that? So if you think that we should have a system to place some priority on who gets treatments during a pandemic or another large public health emergency, vote yes, A. Send a text, B, no. And for a while there, we had 113% saying yes, we should, which is really impressive. So that's good. And you all are, have thought about this already a little bit, which is great. It's interesting in the community when we ask these questions, generally speaking, even after just a little bit of introduction, it's still 100%. Everyone, from the citizens, people who work in grocery stores, people who are nurses, everyone agrees there should be some priorities. Then you get into the questions about, how do we set those priorities? So let's say there is a severe influenza pandemic. Thousands are critically ill. Hospitals are overwhelmed. The entire nation is impacted. This is going to last for months. Maybe it's similar to the 1918 Spanish flu. It's bad. So there's lots and lots and lots of hospitalizations and deaths. We don't have enough ICU beds. So there's a number of ethical principles that we can use when we decide about who's going to get the resources. We could opt to save the most lives. We could opt to maximize the number of life years of the patients that we were going to save. So-called the fair innings effect, that if you're in sort of the 8th inning of your life, that you probably don't have quite as much priority as somebody who is in the 1st inning of their life. So prioritizing the younger folks. Life cycle principle, very similar. If you sort of lived out a full life, maybe your priority is slightly less than folks that have not had that opportunity. Instrumental value. This is sort of a little bit of a side discussion. We'll come back to this, but should medical providers, for example, get priority? It's pretty interesting, though, because if you start talking to citizen groups about instrumental value, there's very, very few people who don't feel like they're instrumental to the community. You don't get a lot of people saying, you know what, I'm kind of useless, so don't worry about me. It's like, well, hey, people that work in grocery stores, you have to have those, you've got to have truck drivers, you've got to have, and so pretty soon, you've got an awful lot of priority groups. Or you could just say first come, first served. We're open free beer, but only for the first 100 people. Free vaccine, only for the first 100 people. Maybe that's the way to do it. Or maybe you have a lottery. Maybe we have people do scratch-off tickets to see if they got vaccine this week. So the saving the most lives principles, those with the best chance of surviving would be given priority. We would use severity of illness scoring systems and other things to determine that. So that's one way. Maximizing life years, we talked about in also incorporating an impact of the patient's underlying illnesses. So if you have a life-limiting illness already going into getting pandemic influenza, we would take that into account. Life cycle, I mentioned, younger have been through fewer life stages. Instrumental value to the community, first responders, healthcare providers, first come, first served. Right now, that's kind of how we do it, although not quite. I mean, if you're in front of me in line, but I have a knife sticking out of me, generally speaking, I am going to get prioritized over you in the emergency department, unless you have two knives sticking out of you, in which case you might get priority. But I might take another one of those and stab myself, and then we'd be right back where we started. So anyway, you have to. There may need to be some inclusion criteria or some processing, but you could use first come, first served, and then we could use a lottery in certain circumstances. So, and I'll cover a little bit of this also as in my presentation, but there's some factors that we should not consider, should never consider when we're dealing with allocation decisions, and those have to do with ethnicity, gender, socioeconomic status, whether or not you're insured, citizenship, religion, and then sexual orientation. So definitely some factors we don't want to have people weighing into the balance. And you'd kind of look at that side and go, who would possibly do that? But I had a surgeon who was presenting at a conference that I was at that was in Michigan, who said, the first people we're not going to give resources to are the fat people and the smokers. And it's like, okay, is my time up already? But that's the kind of thing that really reflects some very inherent biases on the part of that surgeon. That obese or smokers may have underlying diseases that might contribute to some decision making. Categorizing those people in that way is unfair. Categorizing the way they did if you read the book 5 Days in Memorial, and if you haven't, that's a really good book for a couple winter evenings of fairly gripping reading about the decision making that occurred in Katrina at Memorial Hermann Hospital after the hurricane hit, and why we need crisis standards of care. That those were ad hoc decisions that were very poor decisions, using DNR as a triage tool, and yeah, it's gripping, and if you have a chance to read it, please do. How often is it acceptable to use the principle that we give priority to those most likely to survive? So if you think that's a principle that we should be using in our considerations, vote A, never, B, sometimes, and C, we should always be giving priority to those most likely to survive. So, yeah.
GoToMeeting's having a hard time here.
Uh-oh. Is this the GoToMeeting mic?
The other one.
The other one. We'll just try changing those around here a little bit and see what we can do. Okay, for those on GoToMeeting, please let us know if this is a little bit better. We'll do our best here. So never 5%, shouldn't be looking at how likely the person is to survive the illness, and then sometimes and always kind of fighting it out there for about equal. How often do you think we should apply the principle of life cycles, or those who are most healthy and most likely to live the longest, the life years? How often should we weigh that in? If A is never, B sometimes, and C always, just text either A, B, or C. Oh, never sliding down from 8% to 6%. So this would basically be, giving the youngest and most healthy the most priority, oldest and sickest less. So sometimes 70%, a little bit, but less concordance than we had about survivability in the first one. How about the principle of life stages, that basically those who are younger and have not lived through the largest number of life stages, should we take that into account? Never, sometimes, or always? And it's interesting, always is not getting a lot of play here, a little bit there. We're kind of balancing between never and always, and then pretty good amount of sometimes. Dr. Daniels, who, this is one of the proponents of this ethical principle, would be proud of you guys for at least wanting to include this in some considerations. And don't forget, these are not mutually exclusive. A lot of times, it comes down to, first we might look at survivability, and if there wasn't a clear-cut reason to make a decision there, then we might look at life cycle or look at some of these other factors. How about the principle of instrumental value? If you do have a healthcare worker, for example, who would they get priority for vaccine or priority access? Do you think we should never do that, sometimes, or always give priority to those of instrumental value to the community? And granted, we're preaching to the choir here a little bit because most of you are in public health or in the healthcare community, so it's like, never. I don't want to take that away. So, but it's interesting that always 23%, and I guess, and I'm not going to ask you to re-vote, but I do think there are certain circumstances in which, if you can keep me at work and keep me caring for people, then I think it makes a lot of sense to the community that we should have priority access. If it came down to something like a ventilator, where there's no way that you're going to get me back well caring for people during a pandemic, that might be a little different. So my feeling is that sometimes it's by category of the resource that we're talking about, things do vary a little bit here. How about first come, first serve? Should we never use first come, first serve? Sometimes use first come, first serve, or always? So not too many, nobody's in favor of always using first come, first serve, which is good. And it's interesting again, because first come, first serve might have some applicability for certain things, but it might be, kind of down the road. It's generally not something that we want to use, but a lot of times in the healthcare system on a daily basis, it's what happens. And so, if there's an expectation of the public that like, well, I got here first, I should keep that ventilator, or I got here first, I should have access to this. Sometimes those are going to be a little bit hard to work with. How about a lottery? Should we never use a lottery? Should we consider using lottery in certain circumstances, or should we always use a lottery? For those of you that like lotteries. Somebody likes a lottery. All right. So not a lot of fans of the lottery here, which I think is good. I think there's very few circumstances in which you would have a population where you would have no good reason to distinguish between any groups, and you would just say, okay, we're going to give out numbers. At the same time, let's say that you had 5 doses of a Zika vaccine and 40 people that just got back from Mexico that all got pregnant down there, and they all want to have the vaccine. Well, you're going to be stuck because you don't have enough, and if they're all young and healthy, which they probably are, maybe a lottery, might be the best thing to do. But in general, lottery is not a circumstance that we'd really like to put ourselves in. So of the principles here, you now need to choose which one you think would be the best overall to guide our decisions about ventilators and life-saving resources. So we're really talking about something that's got the potential to get someone through an illness and survive. Do you think we should overall consider those most likely to survive the illness? Should we get the resources? B, those who are otherwise healthy and likely to live the longest, even if they're not the most likely to survive. C, those who have lived fewer of life stages, so younger get priority. D, those who would, and don't vote yet, D, those who would be of most value to others or instrumental value to the community. E, first come, first served, or F, lottery. So choose the one that you think should be our guiding principle, even if others might come into play sometimes. So A, most likely to survive. B, healthy and live the longest. C, fewest life stages. D, instrumental value. E, first come, first served, and F, lottery. Very interesting. And this does parallel, you know, when similar work has been done both with, you know, citizens in Harris County, King County, a number of other different places. Generally speaking, you know, a lot of the conclusions wind up coming back the same as the work that, you know, Maryland has done here and what we're seeing on our poll today. You know, that these are fairly common choices. There is amongst the general public a little more tendency to choose C. I think a lot of that just has to do with we always have a tendency to give priority to children, our own or others. That's a very understandable thing, and honestly, there's some, you know, ethical grounds for that too. Not necessarily in every culture, as we'll talk about a little later, but in general. So do you think there are situations in which healthcare providers should remove a ventilator from one patient who needs it to survive and give it to another who needs it to survive? Yes or no? Should we ever put ourselves in that circumstance? And this is a pretty tough thing. And again, this is a very extreme circumstance. Even in crisis standards of care, we do have thousands of ventilators in the federal stockpiles. It really would be a pandemic event where the entire nation is affected. We don't have the resources we need, where you'd have to deal with something like a ventilator. ECMO, things like that, you know, not as clear-cut on, you know, who is the best to put on to get through, you know, with ECMO, but that's a vanishingly scarce resource and something that we may have to make these decisions about, you know, pretty routinely actually with epidemics. But 83% for in certain circumstances, and 17% say no, we should never do that. So, and we'll talk obviously more about this in my presentation upcoming.